A very good evening, all, dear my professional colleagues, and thank you, Harish, for your kind introduction. This is Dr. Sepuri Krishna Mohan, Endocrinologist, my own center, Sepuri Diabetes and Endocrine Center, Karnool. So today we are going to talk about the use of premix insulins in Indian context. Next slide, please. Yeah. So this is the flow of contents. Today's topic is been divided into multiple parts. The unique characteristics of Indian type 2 diabetes mellitus people and the risk associated with uncontrolled PPG levels and insulin in the Indian context, the guideline recommendations and case-based discussion, and the insulin initiation with the premix insulin, and finally the take-home message. Next slide, please. How are Indian type 2 diabetes patients different when compared to the Caucasians, basically, the whites? And this is an important slide which shows the dietary survey results in an Indian type 2 diabetes population. This is called START study, where they calculated the consumption of starch in all parts of the India, that is taking the northern part and the southern part, the western part and the eastern part and the middle part, the central part of India. And you can very clearly see the total percentage of carbohydrates is around the central is 67 and the east part they are consuming 65% of the dietary intake is mere carbohydrates, and 64% in the north, 61% in the west with 64, and on average the conclusion we can come to is when compared to the proteins are very less, and the fats are also not so high actually. So the data from this present cross-sectional study, the STAR study, that shows that the carbohydrate constitutes the main ingredient of the meal actually, and that is to a tune of 64.1% of the total energy from diet in the type 2 diabetes group, which is higher than the recommended level. This is surprisingly not only the type 2 diabetes population. On an average, this is the consumption of every Indian actually. The 60 to 70% of carbohydrate they are consuming. And there was a clear non-adherence, that is self-reported to dietary advice in the type 2 diabetes group, and the inference is the Indians consume around 64% of carbs in their diet. Next slide, please. And you can see this table actually, the relative contribution of the PPG to HbA1c when Indians were compared with the Caucasians. So you can very clearly see on the left hand side the studies done on the Indian population, and the studies the right hand side you can see the studies done on the Caucasian population. There are multiple studies and parallelly, and when you compare this the Indian fasting plasma glucose and the postprandial glucose, so the same HbA1c of 8.2% in this study, first of all the Dakel Gian et al, when compared to the Feden et al, that shows the fasting plasma glucose is around 158 and the postprandial plasma glucose contributes to tune of 223 milligrams per deciliter, whereas the same when it comes to the Caucasian population, the fasting plasma glucose is 149 milligram per deciliter, and whereas the postprandial is around 233. It is definitely higher by 10% actually. So this is the multiple studies showing the different the A1C levels and the corresponding fasting and the postprandial glucose levels from 8.2% of A1C to 9.8% of A1C. The inference is as HbA1c increases, the PPC contribution increases in Indian population versus the Caucasian population. See, usually the majority of the HbA1c is contributed by the fasting actually, but whereas in the Indian population it is the reverse actually. Next slide please. So the risk with uncontrolled postprandial glucose. This is a very important topic actually. So the several studies have shown that the normal fasting plasma glucose and an abnormal postprandial excursions. There are major seven studies done on this particular perspective. Out of which the most popular is the Honolulu study actually. Honolulu is the capital city of Hawaii. Hawaii is the state, the 50th state in the United States of America, but it doesn't belong to this particular the United States of America. It is somewhere some thousand kilometers, thousands of kilometers in the Pacific Sea actually. So they have shown that this particular high postprandial glucose when compared to the normal fasting plasma glucose is associated with the cardiovascular mortality and morbidity. And this slide shows as uncontrolled postprandial hyperglycemia may lead to wide array of complications. And in the middle you find the postprandial hyperglycemia, which leads to the macrovascular disease on the one hand, and the increased carotid intima media thickness and the decreased myocardial blood flow and volume, the impaired early diastolic dysfunction, the increased oxidative stress, the increased inflammatory markers, and the increased risk of retinopathy, and the increased risk of pancreatic cancer, which is very, very important. See, the basic the etiology of pancreatic cancer is smoking, and followed by the presence of type 2 diabetes for a longer period, that is 10 to 15 years of type 2 diabetes mere itself becomes a risk factor for pancreatic cancer, and that too with a high postprandial excursions, high postprandial hyperglycemia. So next slide please. So this shows the table shows in any category of fasting glucose, an increase in PPG, that is 2-hour PPG, resulted in a significant increase in mortality. That is especially true with the cardiovascular disease, that is either the coronary artery disease or the strokes. Say the inference is the postprandial glucose is an independent marker of mortality in different ways, what we have seen in the earlier slide actually. Okay, next slide please. So more patients achieve HbA1c targets by adhering to PPG targets than FBC targets. Okay, you can clearly see the right hand side, the left hand side, the diagram, and on the right hand side you can see the cartoon, and the percentage of patients achieving A1C target of around or less than 7%. So we generally talk in the sense of milligrams per deciliter. Our scenario is that, and whereas the other the Europeans and even the Americans also they follow the millimoles per and so in patients achieving on the I am talking about the left hand side cartoon, patients achieving fasting plasma glucose target of around or less than 100 milligram per deciliter, and it was 64% they achieved actually, and 36% did not achieve. And in contrast to this, the right hand, which is basically related to the postprandial targets, patients achieving postprandial target of around or less than 140 is it is yes for 94% and no, that is 6%. The basic inference is control of fasting hyperglycemia is necessary. That is what we say all the time. Remember 3 F's. Fix the fasting first. unless you fix the fasting first, you cannot fix the postprandial. So control of fasting hyperglycemia is necessary, but usually insufficient for achieving HbA1c goals of around or less than 7% as recommended by the American Diabetes Association. See, other international bodies have got other A1C levels, like the American College of Endocrinology or the American Association for the Clinical Endocrinology. They say it is around or less than 6.5%. But we follow the American Diabetes Association, which is reasonably good. 7 is that the patient will not get into hypoglycemia, especially the nocturnal hypoglycemia, especially the level 3 hypoglycemia. And control of postprandial hyperglycemia is essential for achieving the recommended HbA1c goal. Next slide, please. So, insulin in Indian context. Next slide, please. So, are we starting the insulin at right time? So, I can bluntly say absolutely not. So, the intensive treatment with OADs over a certain period has shown control, but eventually the glucose levels continue to rise steadily. This is because of the pancreatic bankruptcy. Actually, the death rate of the functioning beta cell is around 4% per annum. That is a relentless process. Whether the patient is under control or out of control, that goes on continuously, and eventually when it reaches the pancreatic functioning beta cell reserve reaches the around or below 25%, no oral drug is going to act. That is high time you have to use insulin. But earlier the better. That is, the early initiation of insulin is the best policy, rather than waiting for the pancreatic bankruptcy and the non-functioning beta cells going below or around the 25%. So in India, insulin therapy is initiated only when the A1C levels have deteriorated to around 9%. See, the recommendations from American Diabetes Association guidelines, even the 2024 guidelines have ruled 10 days ago. They also say that the patient must be put on insulin once the A1C is around or more than 9%, with or without the existing OADs. That depends on the clinical acumen and the clinical judgment of that particular the treating clinician. Actually, the therapeutic inertia for initiation of insulin therapy still exists, and you can have all the references. This delay may result in an increased risk of diabetes related complications. Absolutely yes. And hence a timely initiation of the insulin becomes imperative for reducing the future risk of diabetes related complications. See, the basic defect lies with this. See, one single word I just have to use, that is the inertia. The inertia may be from the patient side or from the treating clinician side. Okay, there may be the clinician's inertia or the patient's inertia. Even the doctor says insulin, the patient reluctantly says, sir, I don't want to be insulin. I rather die rather than taking insulin. That is called the patient inertia. When the doctor advises, the patient says no. That is the patient inertia. When the doctor doesn't advise at all, that is called the clinician's inertia. Both are equally important, and both are equally the culprits in this particular initiation of insulin. Next slide, please. So these are the types of insulin. All of you know there is the basal insulins and the intermediate acting, and then the long acting, the detumer, Glargine U100, Glargine U300, the degludec U100, degludec U200, and then the prandial insulins, and the short acting insulins, that is regular, the rapid acting analogs, that is the Lispro was the first in the world, the first rapid acting analog, and followed by aspart, followed by glulysin, and faster acting analogs have come. That is Fiasp is called the fast acting insulin aspart is called Fiasp, and likewise The Lispro people also have come with a faster acting the Lispro. The brand name is Lumjo. And the premixed insulins, that is 70 bar 30 NPH bar regular, 70 bar 30, 60 bar 40, 50 bar 40, but these are all not available. 60 40 are not available in our country, and usually we have 30 70. 30 is the regular one and the 70 is the NPH, and we have 50 50, that is regular as well as the NPH. And the Lispro has got 75 25. And in the abroad, in the United States of America and in the European Union, actually the EMA, that is European Medical Agency, has got approval for the 90-10, actually, the 90 being the basal insulin, and the 10 being the regular insulin, actually. So 50 50 Lispro, Protamin and Lispro. Next slide, please. So this slide shows the human insulin formulations, short acting. On the left hand side you can see the absorbed, they are absorbed very quickly and last for several hours, that is the Insuman, the brand name, the rapid and the act rapid, actually. See, the intermediate and long acting, more slowly absorbed, lasts for up to 24 hours. This is actually wrong. This slide is absolutely wrong. I am sorry for that. Insulatard is not the example. Now there is no human insulin is there. Some 20 years ago there was one insulin which I used to prescribe called Ultra Lenti, which used to work for 24 hours, actually, and because of the high incidence of hypoglycemia, that's been removed from the market 2 decades ago. And Insulatard is one that is the NPH, that is neutral protamin Hayes-Don insulin, that works for a period of 12 to 15 hours max. So it has to be given twice a day. So Insulatard is not an example for long acting insulin that lasts for 24 hours. There is no human insulin which acts for 24 hours as on today in the Indian market or even in the abroad. And the premixed, actually the mixture of short and long acting insulins, the biphasic premixed human insulins, that is okay all the time. They are not supposed to mention the brands, but they have mentioned it straight away. I am sorry for that. And analog insulin formulations, rapid acting, they are absorbed very rapidly. See, these are all the analogs what we have now. This is the era of analogs. I don't say that the human premixed biphasic insulins are over. Still 90 to 95% of my daily prescriptions are only for human biphasic premixed insulins, and only 5% is for the analogs, because the biggest barrier to prescribe the analogs is the cost. They have an edge, they have an advantage over the human biphasic premixed insulins, but when you come to these analogs, whether it is the premixed analog, the biphasic insulins, whatsoever it may be, whether it is the rapid acting or the long acting, they are very costly when compared to the benefits they offer. So the rapid acting absorbed very rapidly, lasts only for few hours, and the maximum period it lasts is around 6 to 8 hours, and aim to control the postprandial glucose only. They are called the prandial insulins. That is the reason they are called the mealtime insulin or the prandial insulins. These are the examples they had given in the the reversal, that the Lispro was the first one, then aspart, and then glulysin. So the long acting, the more slowly absorbed to provide the, that is glargine U100, glargine U200, and the detrimer that doesn't stand in the fray at all, that doesn't stand in the battle with this the glargine and the this particular the degludec 100 and degludec 200. So The ultra long acting, very slowly absorbed, designed up to more than 24 hours, that is Glargine U300 and Degludec U100 and Degludec U200 and premixed actually. So the mixture of rapid and intermediate long acting insulins, that is yeah, so suppose you have Lispro, it's a combination of Lispro and protominated Lispro. It's a combination of, if it is aspart, it is the combination of aspart and protominated aspart. If it is glulysin, that is the glulysin with the protominated glulysin. The protomination is only to extend the duration for a period of at least 12 to 15 hours. That's all. So all these are to be given twice a day. So next slide, please. So coming to the guideline recommendations. Next slide, please. And these are all the recommendations from the global and Indian guidelines for insulin initiation. I told you, like the American Diabetes Association and the American Association for the Clinical Endocrinologists and the International Diabetes Federation and the CDA, that is Canadian Diabetes Association, they recommend to start with basal insulin alone. So there are multiple methods of initiating insulin to a patient. Whether the patient is insulin naive or drug naive also. Newly detected type 2 diabetes patients, maybe the patient is using the OADs for a long period, maybe 1 OAD, 2 OADs or 3 OADs. Maximum is 3 OADs. If it is not controlled with the maximum dose of 3 OADs, it is a dictum that you should move on to insulin. There are multiple the formulations of insulin you can opt. The best one is to start with the basal insulin at once a day, either the night 10 o'clock or evening 5 o'clock, depending upon the situation and the condition of the patient. So all the time remember, basal insulin has to be used with the existing OADs. You cannot withdraw OADs and put the patient on insulin, the alone basal insulin. The next day the patient will be like running the blood sugar of 400 to 500 milligram per deciliter. So this is the one way, and the second method is you can go for this particular the basal bolus, and the third one is the biphasic premixed, and there are so many methods. That's what. Okay. So the National Institute for Health and Care Excellence, this is pertain to the UK actually. See, this is called NICE guidelines, we say, National Institute for Health and Care. This is NICA. NICE is pertain to the United Kingdom, and it has released, it doesn't give yearly updates like ADA gives annual updates, ACE gives annual updates, AAS gives annual updates, but this rarely updates itself. NICE. Recently, the updation was in the last year, 2022 was the recent updation, whereas the ADA has given the 24 already, 2024 guidelines are on the net actually for the last 10 days. They recommend to use either the basal insulin or the premixed insulin. And our Indian, the Research Society for the Study of Diabetes in India, that is the RSSDI, and the European Association of the Diabetes Study Group, and the Diabetes Australia Clinical Practice Guidelines, and the Malaysian they recommend either the basal insulin or the premixed insulin or the insulin co-formulations. Next slide, please. So this is a very busy slide. These are all the recommendations for insulin initiation. The ADA guidelines 2023 and the ADA bar. Now there was a big conflict between the European associations and the American associations from the beginning. There was a Cold War going on, and from the last more than 1 to 1.5 decades, they have joined hands together. The ADA and the EASD, that is European Society for the Study of Diabetes, have joined hands and started giving a joint consensus of recommendations for the use of drugs in a case of type 2 diabetes. So the ADA bar AST consensus report 2022 and the Canadian Diabetes Association 2018, the AAS's 2022, that is Association for the American Association for the Clinical Endocrinologist 2022 guidelines, and the International Diabetes Federation guidelines 2018. They all say that the insulin must be initiated at an appropriate time, not waiting for the pancreatic bankruptcy, where the patient literally stands at the stage of the pancreatic bankruptcy, or we call it the secondary OAD failure. Please don't wait until the secondary OAD failure, so that you need to use the large amounts of insulin, and on top of it, you need to use insulin lifetime. Next slide, please. Yeah, these are nice clinical practice guidelines updated 2022. So you can see the guidelines. Okay, this is a busy slide. Okay, and it says consider premixed or biphasic preparations, whether it is the analogs that include short-acting insulin analogs rather than the premixed biphasic preparations that include short-acting human insulin preparations. If the person prefers injecting insulin immediately before a meal, the hypoglycemia is a problem. The blood glucose level rises markedly after meals. See, I tell you this context, the basic difference between the biphasic human premixed insulins and the biphasic analog premixed insulins is that the thing is, the as long as the human insulin is in the bottle or in the cartridge, whatever it may be, it is in the form of a hexamer, 6 atoms. So once it is introduced into the subcutaneous tissue of the body, that is the preferred site is abdomen insulin all the time. So once it is injected, that breaks down into dimer, and finally it breaks down into a monomer, and the monomeric insulin is the active principle of any insulin. So this process takes around 30 minutes. So that is the reason why we always ask the patient to wait for 30 minutes. Suppose the patient takes this particular biphasic human premixed insulin at 8 o'clock in the morning, we ask them to take the breakfast after 30 minutes, because unless the monomeric insulin, which is the active insulin, is not formed, there is no point in taking the food. If you take the food, the blood sugar shoots up, and then this monomeric insulin has to run after that, like a cop chasing the thief. So that is not possible actually. So you need to wait for 30 minutes, and if you wait for 30 minutes, it effectively controls. Absolutely, I don't say that the biphasic human the preparations are useless. I never say that. And if the patient has got affordability, the advantages are, and second thing is, the second side effect of this particular the human insulins is, like it tends to get the patient into hypoglycemic events. And third thing is, it increases the weight. These are the three major disadvantages. The last two are the side effects, whereas the adverse effects, the first one is the mechanism. You need to wait for half an hour. So sometimes it may not be possible for some people, the executives, the top-notch people who cannot afford to wait for the 30 minutes. And in contrary, the when it comes to the biphasic premixed analog insulins, the advantage is that it is already in the monomeric form. The moment you inject into the body, it starts working. That is, you can take just 5 minutes prior to the meal. Instead of waiting for 30 minutes, you can take and you can eat. That's all. And even you forget to take, in the middle of your meal, you can have the insulin, then also it works. Sometimes the patients, they forget to take the insulin. Even after the meal, you take that the biphasic premixed analog insulins. Even you take after the meal also, that works very fast. See, this is the first advantage. Second advantage is it doesn't have the incidence of hypoglycemias when compared to the biphasic human premixed insulins. I don't say that these are totally devoid of hypoglycemias, but usually the incidence is very much reduced. And when compared to the hypoglycemia as the level 1, level 2, level 3, usually it is confined to L1 hypoglycemias, and when compared to the nocturnal hypoglycemias, the incidence is very much reduced. What is the problem with biggest problem with the nocturnal hypoglycemias is the hypoglycemia unawareness patients. They don't know that they are into hypoglycemia in the night. They die miserably by the time they get the medical aid. So this is the greatest disadvantage of nocturnal hypoglycemia, which is very much reduced by the usage of this the biphasic premixed analog insulins. And third thing is it doesn't increase the weight, at the same time it doesn't decrease the weight. Most of them are weight neutral. That is the difference between that. Okay. Now coming to the Indian guidelines, and you can go through the RSSDI guidelines 2022. Initiate with once daily basal insulin, once daily premixed or co-formulation insulin, or twice daily premixed insulin, either alone or in combination with the other OADs based upon the patient's age, clinical features, the glucose profile, the risk of hypoglycemia and the patient's preference. Basal insulin may also be initiated in combination with the GLP-1 analogs. See, the greatest advantage of the insulins is that can be combined with any of the oral anti-diabetic drugs except pioglitazone. Pioglitazone and insulin should never be combined because of the fear of the volume overloaded state. They suddenly take the patient into a volume overloaded state wherein the patient may suddenly land up in acute heart failure. So that is the reason we are not supposed to mix with the thiazolidinediones. The only thiazolidinedione we have at present is pioglitazone. Though there is lobeglitazone, I think it's virtually a useless molecule. See, pioglitazone is a wonderful molecule if it is used judiciously, cautiously. That is the one. And second thing is it can be used with the latest subset of group, that is the injectable hyperglycemics. That is the GLP-1 receptor agonists, like the starting from the exenatide to the liraglutide to the semaglutide to the tirzepatide and all. The latest ones have come. Only thing is they are very costly. They have got a lot of benefits. They are especially very beneficial in patients with the atherosclerotic cardiovascular disease, where the atheromatous plaques they play a vital role. There you find the greatest benefits of the GLP-1 receptor agonists. Now all the including the dulaglutide, though albiglutide is virtually useless, the exenatide also is virtually useless, and liraglutide and semaglutide and tirzepatide scores over all. Tirzepatide is the number one GLP-1 receptor agonist that has got a dual pathways, that is the GIP-1 and the GLP-1 receptor agonists. So they are the drugs of choice. Though injectables very costly, once in a week, they reduce the weight very significantly. That is the greatest point. So they can be combined with insulins. So insulins are compatible with everything and anything you can use for any diabetes patient except thiazolidinediones, that is pioglitazone. So coming to the Royal Australian College of General Practitioners, that is Australian Clinical Practice Guidelines 2020, they select one or two insulin schedules, either the basal insulin, that is the Glargine U100 or Glargine U300 once daily irrespective of meals, and co-formulated insulins, that is insulin degludec and insulin aspart. The only co-formulation available in the world is insulin degludec and insulin aspart, or the premixed biphasic insulin like Lispro, protominated Lispro, and aspart and the protominated aspart once daily before the largest carbohydrate containing meal of the day. See, to tell you very honestly, these recommendations, I don't think they are not correct actually. See, you can all the time use the co-formulation, insulin co-formulation, that is insulin degludec and insulin aspart, with the largest meal of the day. The rest of the things have to be given twice a day. Otherwise, they are virtually useless because the efficacy loss for the plasma half life is less, and it lasts for only 12 to 14 hours. And coming to the European Association for the Diabetes Study Group Clinical Practice Guidelines 2018, they say the preferred method of insulin injection is to begin by adding a long-acting basal insulin or once daily premixed or co-formulation insulin or twice daily premixed insulin alone or in combination with glucagon-like peptide GLP-1 receptor agonists or in combination with the other oral anti-diabetic drugs. Next slide, please. So this is the convenience of insulin. Insulin can be added at any point of time, can be taken off at any point of time. You think it is not required. The patient is maintaining well after some time. The body has got saturated with insulin. You can stop insulin and see whether the patient is doing extraordinarily well with the OADs. You can just continue with the OADs also. So it's something like a joker in the which is very useful in the playing cards. Actually, insulin is more than like a joker. See, it gives you life actually. See, the factors indicating premix as choice of insulin and choose of premix insulins. These are all the take-home messages. The premix insulin such as Lispro, premix 25 provide control of both fasting plasma glucose and the postprandial glucose along with the convenience of initiation, titration and intensification. Any insulin you initiate, it has got three parts all the time: initiation, titration and intensification. Yes, next slide please. So the patient selection as far as premix insulin, this is a very busy slide. Okay, next slide please. And the considerations at initiation, either you should go for either premix or the basal. So these are all the points which on the left hand side which favor the premix and the right hand side which favor the basal. See, what is the postprandial increment, and is the patient likely to manage the basal bolus therapy when intensification is needed? Is there a large carbohydrate intake at one or two meals? Is the patient's lifestyle predictable? Sometimes the lifestyle is predictable and sometimes, most of the times, the lifestyle is not predictable in our scenario. That is the eating patterns and the working hours. See, everybody talks about the carbohydrate count and all in the Western scenario. But we don't even know what carbohydrate counting is. That is the miserable part. When the doctor doesn't know how to calculate the carb count and how he is going to the insulin carb ratio, when the doctor doesn't know how he is going to counsel the patients, is a $1 million question in India. Okay, next slide please. So this is the meta-analysis results of the premixed versus the basal insulins. This is an analysis of 13 randomized controlled trials lasting for 16 to 60 weeks. The number included is 5,000 and change, and the non-significant, that is 0.9% difference in A1C levels achieved by the two decimants, and the premix and the basal bolus showed no significant difference in the rate of hypoglycemia, weight change and daily insulin dose, despite the greater complexity of the number of injections associated with basal bolus insulin. The factors that affect the choice of the intensified insulin regime is the number of injections, which are certainly fewer than the premix insulins, the self-monitoring of blood glucose, which will be less frequent with premix insulins, and the patient's ability to inject insulin, which will be convenient in case of premix insulins. Next slide please. So this is the insulin therapy with type 2 diabetes, which regimen for intensification is justifiable. So you can see this. This is a busy slide. Okay, next slide, please. And let us take some case studies. Okay, next slide, please. So, first case, role of premix insulin in patients with uncontrolled diabetes who are on OADs. Yeah. So, T2DM patients uncontrolled on OADs. This is the common clinical scenario we encounter in the day-to-day practice. You all are the treating the diabetologists or the clinicians, maybe primary care clinicians, or the physicians or the endocrinologists, whoever it may be, anybody who is treating diabetes in a very methodical way, it's highly appreciable that as far as you confine yourself to the recommendations, international recommendations. So a female patient, 52 years of age, and the clinical history is type 2 diabetes treated for 12 years and A1C was 9.3. At last visit 6 months ago, that is terribly out of control. The patient weight has been stable since last visit. Okay, I don't know how the patient's weight will be stable when the A1C is 9.3. The physical examination weight is 74 kilos and the body mass index is 26 kilograms per meter square and blood pressure is 130/90 millimeters of mercury and feet and eyes are normal. And lab results, the glucose A1C is 9.3, fasting is out of control 146, post lunch 2 hour PPG is 255, out of control. The kidney function creatinine is good 1.1 and the EGFR is 74 ml per minute per 1.73 meter square of the surface body area. It is normal and USAR is 70 milligrams per gram. This is abnormal actually. The patients now the ADA has changed the terminology from this is microalbuminuria is abolished and they have introduced urinary albumin creatinine ratio in place of microalbumin for the last couple of years actually. From 2021 the term is changed. So this patient is suffering from microalbuminuria, that is USAR is 70 milligram. Anything below 30 is normal, 30 to 300 is microalbuminuria. Above that is the macroalbuminuria or the overt proteinuria. And the lipid profile, coming to this total cholesterol, it is 250 milligram higher side. LDL the 165 milligram per deciliter higher side and HDL 35 lower side and triglycerides 250 milligram per deciliter, it is on the higher side. So there is a dyslipidemia. So the liver function, the enzymes are normal. Next slide please. And the clinical challenge is the reason for visit is blood sugar not under control. So okay, the medications the patient is on is sitagliptin 100 milligram OD, glimepiride 4 milligram a day, metformin 2000 milligram a day maximum dose, atorvastatin 20 milligram like once a day, losartan potassium is 50 milligram BID and chlorthalidone 25 milligram once a day. And the family history is the history of CAD is in her father at the age of 56 actually. Coming to the social history, homemaker, highly social, and the dietary pattern, predictable diet with heavy breakfast and dinner, and complaint with the medications, the hypertension, history of urinary tract infection 6 months ago, not adhering to lifestyle modifications. Next slide please. And let us see the evidence. Next slide please. So these bar diagrams you can clearly see on the left hand side and the right hand side. Comparing the Lispro premix 25 BID plus metformin versus insulin glargine once a day HS plus metformin. So you can clearly see the diagrams. The first one is glargine plus metformin, and the second bar, the red bar is glargine plus metformin, and the The gray bar is the Lispro premix 25 BID plus metformin. You can clearly see the reductions in the A1C are much better with the Lispro premix 25 BID. And coming to the right hand side, the higher percent of the patients treated with the Lispro premix 25 plus metformin attain treatment targets except fasting blood sugars. So we can very clearly see this, and the take home message is the better reduction in A1C and attaining target goals with Lispro premix 25 when compared with the insulin glargine plus metformin. Next slide, please. So the Lispro premix 25 BD plus met versus the insulin glargine, the HS, that is once a day plus metformin. We are seeing here the overall the hypoglycemia actually. See, the overall hypoglycemia is certainly less when compared with this the insulin Lispro 25 plus metformin when compared to the glargine once a day plus metformin, because the glargine being the basal insulin usually, and then metformin doesn't usually have the incidence of hypoglycemia. So this is okay, but when you look at the p-value, it is 0.041. That is, it is not statistically very different. It is not significant at all. See, you say the p-value is around 0.05, then you say it is statistically significant. So it is not falling into the criteria, so it is not statistically significant, the overall hypoglycemia. So also when compared to the nocturnal hypoglycemia also, the nocturnal hypoglycemia, they have shown the high incidence of hypoglycemia with glargine. I think it must be the reversal actually, and the overall hypoglycemia rate was low in both the groups. Nocturnal hypoglycemia was similar in both the groups. Now this is a self-contradictory slide actually. I'm sorry. And going back to the case, the follow-up started on Lispro premix 25 10 units before the breakfast, and dose was titrated at weekly intervals. After 4 weeks, second dose of Lispro was introduced 10 minutes before dinner and receiving 18 units before breakfast, and it was titrated. Further 4 weeks later, she got stabilized at Lispro 25 in the morning and 22 units before breakfast. So 22 units before breakfast and 16 units before dinner. Glimepiride was discontinued. Generally, what we tend to do is, whenever we introduce these insulins, we try to take off or reduce the dose of this particular the sulfonylureas, whatever it may be, whether the first generation or the second generation or the so-called third generation also. Third generation is nothing but glimepiride, and the extended releases of the glycoside are called the third generation sulfonylureas. At 3 months, blood glucose was under control. A1C is somewhere around 7.5%, which is reasonably good, but it should be around or less than 7%. Next slide, please. And coming to the second case, role of premix insulin in patients requiring insulin intensification. Next slide, please. And this case is male, 68-year-old, duration of diabetes is 15 years, and weight is 80 kilos, and body mass index is 26 kilograms per meter square. And the current medication is metformin 500 mg BD, vildagliptin 50 mg BD, glimepiride 2 mg BD, and Lispro mix 24 units before breakfast and 16 units before dinner, and A1C is still high, 9.2. And the 7-point SMBG values, you can see the 7-point formula of monitoring the self-monitoring blood glucose is nothing but the one day you check this particular before breakfast, that is early in the morning fasting, and the second reading must be 2 hours post breakfast, and the third reading is pre-lunch, and the fourth reading is the 2 hours post-lunch, and the next the fifth reading is pre-dinner, and the sixth reading is and 2 hours after the dinner, and the seventh reading is early in the morning 3 a.m. This is only to exclude the dawn phenomena and the Somagi phenomena. That's it. Okay, we rarely monitor 3 a.m. The glucose unless otherwise the patient is type 1 diabetes patients. It doesn't mean that I never mean to say that dawn and Somagi never occur in the type 2 diabetes patients. It occurs in type 2, but when compared to the incidence, it is more than 90 to 95% it is seen in type 1, whereas less than 5 to 10% only we see it in the type 2 diabetes patients. So we generally don't do the 3 a.m. sample unless otherwise it is very much required. And let us see the evidence again. Next slide please. And the similar A1C reduction and the similar proportion of patients achieving glycemic target with Lispro premix 50 compared to the basal bolus therapy. Basal bolus therapy is nothing but giving 3 prandial shots. That is either the human is either the short acting 3 shots and the 1 or 2 shots of NPH. Whereas coming to this particular the analogs, 3 shots of either Lispro or the aspirate or the glulysin with 1 shot of long acting, either the Glargine U100 or Glargine U300 or Degludec or whatever it may be. That is called basal bolus therapy, BBT. You can see both have reduced the A1C by 1.1% on the left hand side bar diagram. And the target A1C on the right hand side you can see the red one is the Lispro mix and the grey one is the basal bolus therapy, and the reductions are from the baseline it is 11.9% with BBT, whereas with the Lispro it is 9.1% of reductions in the A1C. And even you see the next bar diagram also. So it is it clearly shows that when compared to the BBT, that is basal bolus therapy, the Lispro premix 50 has proven to be much better when compared to the basal bolus therapy. Next slide please. The similar overall and the nocturnal hypoglycemia with Lispro premix 50 compared to the BBT, you can clearly see the incidence is, the total is around, it is same, the number is 197 and the 202 in the Lispro group it is 197 subjects and 202 in the BBT, and the inference is similar glycemic control without increased risk of severe hypoglycemia, that is L3 hypoglycemia, with less number of pricks actually. So there you have to give 4 pricks. Here you have to, the basal bolus therapy all the time needs 4 or 5 pricks. Whereas this particular the Lispro premix 25 or Lispro premix 50 they need only 2 pokes. See, the number of pokes is less, the patient compliance increases. That's what. And coming back to the case 2, the patient was switched to Lispro premix 50 one stay from 25, and before breakfast the Lispro premix 25 before dinner, and Lispro premix 50 dose was 20 units before breakfast, and Lispro premix 25 was 16 units before the dinner, and the dose was titrated every week. After 6 weeks the patient was stabilized on Lispro premix 50, that is 24 units before breakfast, and the Lispro premix 25 20 units before dinner. At 3 months A1C was 7.4, near normal. Yes, next slide please. So coming to the summary and probably the last slide, this is the take home message, dear my friends, and significant contribution from postprandial glucose even at higher A1C level in Indian population as compared to the Caucasians we have seen in the initial slides. The premix insulins are simple to start with single injection with effective HbA1c control targeting both fasting plasma glucose and the postprandial plasma glucose, and the patients uncontrolled on 2 or more VIDs with disciplined lifestyle can be initiated on premix insulin, and dose can be titrated on weekly basis. And the premix insulins, they provide convenience and simplicity at initiation, titration and intensification. And premix insulins, they provide both convenience and efficacy to the patient, and aids in achieving the patient's glycemic target. Any more slides? Yeah, thank you so much. And if at all, I kindly request all my participants, the doctors who have participated in this seminar. Thanks for your patient listening. And if at all you have any queries, either you can type in the chat box, or I think you can unmute yourself and you can ask me the question so that I can answer your questions. Pause.